From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Elissa Abrams, who is a professor at the University of Manitoba in the section of pediatric allergy in Manitoba, Canada. Today we will be discussing a JAMA article that she co-authored with Drs. Diagnostic and Broff, titled Peanut Allergy. This article was published online in JAMA on March 11th. Dr. Abrams, thanks so much for joining us on this podcast.
Of course, thanks for having me.
So to start off, how common is peanut allergy in the U.S., and at what age does it typically present?
So peanut allergy affects about 2% of the pediatric population, but what's really important to know is that while it's stabilized now, it actually had increased quite dramatically. For example, there was about a 20% increase in peanut allergy over about a 10-year period in the United States. Also, the number of 2% can be a little bit misleading. It affects 2% of children directly, but we know that it indirectly affects up to 50% of the population. It tends to present when children start to eat food. It tends to happen early with starting to eat peanut, so we tend to see it within the first few years of life.
So you mentioned that 50% of children were indirectly affected by peanut allergy. Could you clarify what that means?
Absolutely. So it means more broadly when you're looking on a population level, about 50% of the population has a relative, a friend, a classmate with a peanut allergy. So even though it affects 2% of children directly, it affects many more people within the population indirectly.
And how commonly do people outgrow peanut allergy?
It's less common than other food allergies in childhood. So if you think about some other common food allergies like milk or egg or grains, most children outgrow it. About 80% of children outgrow it. With peanut, it's much less. You're looking at somewhere between 10 to 30%.
And peanut allergies typically occur within 2 hours of eating peanuts. Can you describe common symptoms of peanut allergy and the organs that are typically involved?
Absolutely. So yes, it typically occurs within 2 hours, but often even sooner than that. We use the 2-hour window as the outside window of when you should see an allergic reaction. But typically, if a young child's going to react to peanut, they tend to react fairly quickly within minutes as opposed to within hours. Most commonly, it affects the skin. So you tend to see things like hives or swelling. It can also affect the respiratory system, so you can get coughing or wheezing, or the gastrointestinal system, and you can get diarrhea or vomiting. In general, it tends to be profuse diarrhea and vomiting as opposed to sort of a bit of abdominal pain or one episode of vomiting. It can rarely in children also affect the cardiovascular system and the brain. So in particular, in infants, they can get quite irritable. In older children, they can get this sense of impending doom. But most commonly, it's the skin. 80 to 90% of the time, we see the skin.
And is it hives or more of a rash?
Great question. So it's typically hives. Rashes by themselves, so a bit of redness on the face, isn't typically an allergy. Usually we see more hives, so big welts that almost look like mosquito bites. The hives and or swelling can happen with other organ systems involved, and that would more be an anaphylactic or more severe type of a reaction.
So anaphylaxis, as you just mentioned, is a severe condition associated with peanut allergy. Can you describe the symptoms and what is the mortality rate from peanut allergy anaphylaxis?
So anaphylaxis has many different definitions. We actually looked at this in the Joint Task Force when we updated our anaphylaxis parameter a few years ago. There's dozens of different anaphylaxis definitions, but the basic core principles are the same, which is that it's a systemic reaction. It happens quickly. It tends to be severe. It has the potential to be life-threatening. And it often involves a combination of the symptoms we just talked about: skin, respiratory system, gastrointestinal system, cardiovascular system, or central nervous system. In terms of the mortality, it's actually very low. A common misperception is that anaphylaxis is often fatal. It has the potential to be. It's certainly a severe reaction, but the actual mortality from anaphylaxis is about 1 in 10 million. And we definitely know in all the studies that have been done looking at mortality with food allergy in general and peanut allergy specifically, that the best way to prevent a serious outcome from an allergic reaction is to use epinephrine early if there is a reaction.
And can you discuss the potential routes of administration of epinephrine?
Sure. So this has been a really exciting area in allergy because it's the first time that it's changed. Historically, epinephrine has been mostly available sort of for community use as an intramuscular route, so as a pen, for example. And only in the past year or two is there now an intranasal form of epinephrine available, like a nose spray that you can use instead of an injectable form. This is the first time in history. And there's more and more research looking at whether epinephrine can be administered other ways. So, for example, there's now studies looking at sublingual routes of administration of epinephrine going under the tongue. And one of the reasons we're really looking at that as a specialty is that one of the big barriers to using epinephrine has been the injection historically. And we know just how beneficial and important it is to use if there is an allergic reaction.
And just to mention, the Food and Drug Administration in the U.S. approved the intranasal epinephrine in 2024, correct?
Yes.
So, for the diagnosis of peanut allergy, your article discusses the importance of clinical history and confirmation of the diagnosis with skin testing or blood-specific immunoglobulin E, or IgE testing. Can you describe these tests? How are they performed, and how should they be interpreted?
That's a great question. And it's something we talk about a lot in clinical practice because allergy testing, whether it's blood testing or skin testing, is very predictive if there's been a history that's suggestive of a peanut allergy. So if a child comes in and they've had an immediate reaction with skin and breathing problems almost immediately after eating peanut, and then their testing is positive, it's a good predictor that they might be allergic. The problem with our allergy testing is that there's a really high rate of false positives. So you can get very high false positives that are quite common. In fact, about 40% of positive allergy testing is thought to be false positive tests, especially if the child is otherwise atopic, for example, if they have eczema. So the testing is really only valid if there's been a good clinical history, which is why, in general, we tend to recommend against, for example, things like testing before a food has been eaten. The tests work in two different ways, but the basic premise is that we're looking at whether a child's allergy system will respond to peanut. So the skin testing, we take a bit of peanut protein and it's an epicutaneous test. So it's a bit of a scratch under the surface of the skin. And then we watch the skin for about 10 to 20 minutes. And what we're looking for is a little hive on the surface of the skin. For blood-specific IgE, it's doing the same process, but with the blood test, they look in the serum to see if there's binding to peanut. And they're both ways to diagnose peanut allergy if there's been a clinical reaction.
In 2015, a clinical trial randomized infants who were aged 4 to 11 months and had severe eczema and or egg allergy to 6 grams of daily peanut protein or avoidance of peanuts until age 5. It's important to note peanuts should not be given to infants or any young child before the eruption of molar teeth because of the risk of aspiration of nuts and fragments. Can you discuss the results of this study and how has it changed practice guidelines regarding introduction of peanut-containing foods into the diet of young children?
Absolutely. So the LEAP, or Learning Early About Peanut study, was one of these fundamental sea changes in our allergy practice. A lot of allergists often joke that every allergist knows where they were when the LEAP study results came out because it so fundamentally changed how we practice allergy. So what this study effectively did was they took high-risk infants and they either fed them peanut regularly until they were 5 or had them completely avoid peanut until they were 5. And they actually had 2 groups. So they had a group that was tested negative to peanut before they started, and they had a group that tested positive to peanut before they started. And what they found in both groups was that eating peanut regularly was incredibly effective at helping to prevent a peanut allergy. There was about an 80% reduction in peanut allergy in the group that ate regularly compared to the group that avoided. And because they looked at both infants who had negative testing and infants who had positive testing, it actually showed both a primary and a secondary preventative effect. This had been sort of coming for several years. There had been some observational studies that had shown that perhaps with avoidance, we were increasing the risks of allergy, and that in places in the world where allergens were fed early, such as peanut, rates of peanut allergy tended to be lower. But this study really speaks within our specialty to that great Einstein quote, "A measure of intelligence is your ability to change," because as a result of this study, guidance has uniformly in allergy changed from stay away from common allergens until 2 to 3 years of age to actively introduce allergens in an age appropriate way in infancy. The old guidelines were really based on this theory that if you allowed the gut to mature, it will reduce the risk of reactions. But what we're increasingly learning is that you become allergic through your skin. And if your gut sees the food first, it tolerizes your body to it if you're a little kid. If you see it first through the surface of your skin, especially if you have eczema, for example, you're more likely to become allergic.
And a 2025 study reported that the incidence of peanut allergy has decreased substantially since the implementation of this guideline. Can you discuss the results of this study?
Yes, so this was a great study, and it was the first US study to really show that with implementation of feeding early, that we can significantly reduce the rates of peanut allergy in the United States. An important caveat, though, is that we haven't seen that everywhere. So if you're looking at other international studies, for example, there was a study in Australia that also looked at early feeding guidance and how it's changed peanut allergy in the population. And they've had huge uptake with early feeding. Over 80% of infants are eating peanut, but they haven't seen a significant reduction in peanut allergy. We don't know the reason why some studies are showing huge benefits and others aren't, but a key factor that many of us think about or hypothesize could be related is the piece about regularity of ingestion. So the big message with feeding early is not just feed early, but feed often. And often the feed early part is implemented. The feed often part is somewhat less so. So sometimes peanut will be introduced, it's checked off a box, and then not fed regularly. And certainly in clinical practice, we see that if that happens, a child's much more likely to be allergic to peanut. And one of the hypotheses about why we're not seeing universally peanut allergy going down is that maybe sometimes peanut is fed early, but not kept in the diet in an age appropriate way.
That's interesting. Moving on to treatment, there are two FDA-approved treatments for peanut allergy, an oral immunotherapy product and the biologic omalizumab. Let's start with the oral immunotherapy. How is this treatment administered, and how long does it last, and how effective is it in terms of desensitization?
So, oral immunotherapy is basically the premise that a child regularly eats the food they're allergic to. So, in this case, if we're talking about peanut allergy, it would be peanut. And you start with a very small amount daily. It's increased slowly over time. And then you get to a final maintenance dose, which is often about 1 to 2 peanut equivalents. We know that whether it's the FDA approved product or more commercial food stuff, because both have been studied, that it's very effective at desensitization. And we more colloquially term that as sort of bite protection, meaning a child, when they finish immunotherapy, is bite protected if they're exposed to peanut accidentally. What we don't know as much is sustained unresponsiveness, or whether they have long-term ongoing protection, even if they stop the therapy. The results there are a little bit more discrepant, and that's certainly an area of active study.
And what are the rates of therapy-related anaphylaxis associated with oral immunotherapy, and are there situations in which doses should be omitted due to risk of anaphylaxis?
Absolutely. So the rates of anaphylaxis are cited at around 14 to 15%, but this is quite context dependent. So, for example, I'm part of a national research group in Canada, and we're looking at real world preschool immunotherapy for peanut, and we're finding much lower rates of anaphylaxis in younger children compared to older children. But across the board, it's about 14 to 15%. Because the therapy can increase your risk of allergic reactions, there are some cautions with the therapy. So, for example, if a child is very sick, for example, has a bad fever or a bad cough, or is having an asthma exacerbation, those would all be reasons to hold the therapy because we want to reduce the risk of a severe reaction if we can.
And moving on to the other FDA-approved treatment, which is biologic therapy, can you describe how omalizumab is administered? How long does this treatment last, and how effective is it?
So, omalizumab and oral immunotherapy are similar in that they're both thought to desensitize. There was just a really pivotal study looking at omalizumab in children with peanut and at least two other allergies, and it showed that it was very effective at desensitizing to peanut as well as to other allergies. It basically binds your allergy cells and prevents them from reacting. So it's not modulating your immune system, but it's preventing the immune system from reacting. And the rates there are similar for desensitization and oral immunotherapy, very, very high. It's also a similar question as immunotherapy in terms of long-term sustained unresponsiveness. And this is also an emerging area. But the studies that have been done so far are actually similar to immunotherapy. We're not sure that if you stop the therapy, it does provide any long-term sustained protection. The protection is mostly while you're on the therapy. The way it works is it's an injection. It's given every few weeks. The first few doses are given under physician or healthcare supervision. And after that, it can be administered at home. The first few visits, there's a few hours of observation after because there is a theoretical risk with this injection of anaphylaxis, although we haven't really seen that much in the studies looking at it for treatment of food allergy.
Before closing, is there anything that we didn't discuss in this podcast that you'd like to mention?
The only other emerging area that's very, very exciting is other forms of food allergy immunotherapy. So in addition to oral immunotherapy, we're also looking at epicutaneous immunotherapy, which is a patch that goes on the surface of the skin, almost like a peanut Band-Aid. And it's a standard patch that's changed every 24 hours with a set dose. And then there's also sublingual immunotherapy or SLIT, which is a very small amount that goes under the surface of the tongue. And SLIT is more like OIT or oral immunotherapy in that the dosing increases over time. When we look at these two therapies, they don't seem to desensitize quite as well as oral immunotherapy, but they also have much lower rates of side effects, including anaphylaxis, compared to oral immunotherapy. So over time, there will be more and more different types of therapies that families can consider for their children with peanut allergy.
And just to clarify, are the sublingual and epicutaneous immunotherapies available clinically now, or are they just in research?
That's a great question. The epicutaneous immunotherapy is still a research tool predominantly. Sublingual, it is being increasingly used in clinical practice, and there are some real-world studies looking at sublingual immunotherapy.
Thank you so much for sharing your thoughts with us about this interesting and important topic.
Thanks for having me.
I'm Dr. Kristin Walter, and I've been speaking with Dr. Elissa Abrams from the University of Manitoba, section of Pediatric Allergy in Canada. You can find a link to the JAMA review article we discussed in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.